I would like to thank the organisers for asking me to present. This was the title of a lecture at a national meeting held in Dublin 3 years ago, and whilst it may appear flippant, it begs a serious question which we'll come back to at the end of the presentation. Going back more than 30 years ago, Rick Holloman from St George's Hospital published a paper on the therapeutic impact of blood culture results. He found that approximately half the patients with significant positive blood cultures had their antimicrobial therapy changed based on laboratory results. He went on to summarise by saying that whilst an antibiotic policy allows effective treatment of many patients, there remains a need for an early microbiological diagnosis. This was at a time when resistance amongst gram-negative bacteria to third-generation cephalosporins, quinolones and aminoglycosides was rare. In the intervening period of time, matters have moved on. Bacteria have not stood still. They have developed sophisticated resistance mechanisms, with ESBL-producing organisms successfully spreading across the planet. We now see the emergence of carbapenemase-producing organisms, which are a global threat to health. Sophisticated technology is now employed in analyzers, which monitor blood cultures every 10 minutes, flagging up positives 24 hours a day. Little, though, has changed in terms of the laboratory response. And whilst it may be tempting to think that the mere presence of such a high-tech piece of equipment with a laboratory is enough, is that all there is to blood culture microbiology? A national telephone survey of 43 laboratories across the UK in 2012 found that no laboratory loaded the analyzer outside of routine working hours, there being approximately a 50-50 split between those at pre-incubated bottles and those that left them at room temperature. The last time a positive blood culture was processed varied between 4 o'clock and 10 o'clock at night during the weekday. This became more pronounced at weekends, with some laboratories not removing a positive blood culture after midday. A specimen flagging positive just after midday would sit on the analyzer for almost 21 hours before being removed to process. Whilst 2 laboratories regularly audited the blood culture pathway, the clear majority never audited. In 2012-13, the blood culture SMI B37 was updated and included a number of recommendations. Audit of the blood culture pathway was key, and secondly, this was the first SMI to set time standards for critical control points in processing. This slide shows the critical control points. The yellow arrows represent opportunities to either gain or lose time, the blue in contrast being relatively fixed once the blood culture is loaded on the analyzer. When auditing the pathway, the starting point should be the time the blood culture collected, not receipt within the laboratory. The national guidance states that 100% of blood cultures should be loaded within 4 hours of collection. NICE guidance also makes demands on laboratory blood culture pathway, as a 36-hour negative blood culture permits early cessation of antibiotics in a neonate if they are well. To see if we could improve the blood culture pathway, a multidisciplinary group consisting of blood science staff and microbiology, biomedical scientists and medical staff, and 3 physicians, 1 consultant and 2 juniors were set up. This is a schematic of the blood culture pathway prior to any intervention. Samples were collected in glass blood culture bottles, preventing them from being placed in the air tube system, requiring a porter to transfer to specimen reception. Chesterfield Hospital is a relatively small DGH, but generates 10,000 blood cultures a year, which potentially could equate to 10,000 portering journeys. On arrival and specimen reception, samples have to be taken upstairs to be loaded onto the blood culture analyzer within microbiology. The delay between arrival and specimen reception and being loaded onto the analyzer in microbiology should not be underestimated. In one hospital, even though microbiology was located 30 metres down the same corridor on the same floor, during the working week, 20% of specimens took more than 4 hours to traverse the 30 metres to be loaded on the analyzer. During the working day, blood cultures which flag positive are removed and processed by microbiology biomedical science staff. Outside of routine hours, samples are left in a standalone incubator and no blood cultures flagging positive are removed. The first action the group took was to move the blood culture analyzer out of microbiology and place it into the centralized reception in blood sciences. This is a centralized reception area in blood sciences over here, and there you can see the blood culture analyzer. This is a slightly different view. Here's the analyzer, and in the background is the air tube system. Blood science staff who work a 24-hour shift system were willing to load the blood culture analyzer 24 hours a day. They keep an image of a septic patient on the analyzer to remind the staff that their work is making a difference. This is an updated schematic following interventions. The blood culture analyzer is now located in centralized specimen reception, so it can be loaded 24 hours a day. Software alerts the biomedical science staff and microbiology to any samples flagging positive during routine hours, so they can remove the bottles and begin processing. Outside of working hours, not only are the blood cultures loaded, but blood science staff remove positive samples and begin processing them. These are subcultured onto media for growth and identification, and 2 sets of sensitivity plates are set up, routine sensitivity plates and rapid sensitivities. The antibiotics selected are for gram-negative organisms, as their sensitivity to antibiotics is unpredictable. For gram-positive organisms, the identity of the organism is usually most important, as once this is known, the antibiotic sensitivity to certain groups of antibiotics can be predicted. The first audit to be performed following the changes looked at the time to positivity following transfer of the blood culture analyzer into blood sciences. It was quite disappointing to find that rather than improving matters, the average time to positivity had got worse, had increased. However, when contaminants were removed from the analysis, which are variable in number and often take a long time to flag positive, it could be seen that there was a clear reduction in time to positivity. When the data was analysed for E. coli, it showed approximately a 20% reduction in time to positivity. A way of comparing our data with other laboratories to see if we had made improvements was required. As E. coli is a common pathogen in blood culture, rarely a contaminant, it was thought collecting data for E. coli would be relatively quick and easy, permitting a coarse comparison between laboratories. This slide shows data on time from collection to placement on the analyzer prior to any intervention. The large rectangular boxes containing numerals just below the x-axis, which appear on many other graphs in this presentation, are there to help visualize the time. Thus, the 2, 4, 8 and 12 represent the time in hours taken to load from collection. The graph is incomplete, as there were samples taking in excess of 14 hours, sometimes more than 24 hours. The group decided the first step was to introduce plastic bottles to facilitate transporting specimens by the air tube system. With glass blood culture bottles, approximately 1 in 5 specimens were taking more than 4 hours to be loaded. Prior to the introduction of plastic bottles, there was a widespread publicity campaign, and as stocks of glass bottles became low, they were simultaneously removed from across the hospital and replaced by plastic. Repeating the audit showed improvement, but still 1 in 20 bottles were taking more than 4 hours. The publicity campaign was repeated, and a further audit still showed 5% taking more than 4 hours. The physicians on the multidisciplinary group said that the urgent requirement for blood culture transportation was not common knowledge amongst clinical staff. It was neither taught at medical school or afterwards. In order to establish a level of knowledge across staff collecting blood cultures, a survey was collected by the 2 junior medical staff. A questionnaire was developed, as seen here, which also looked at CSF and urine samples at the same time. 91% of staff thought a CSF sample should be sent immediately, but only 68% would send a blood culture immediately to the laboratory. This figure fell to only 52% of staff outside of routine working hours. More than a quarter of staff thought it took greater than 48 hours for a blood culture to flag positive. As with many laboratories, a negative 48-hour blood culture report was issued to clinicians. Perversely, this was interpreted to mean it took 48 hours for a blood culture to be processed to register positive. Conversations with a number of junior medical staff who had worked in different trusts said there is often a separate box in the emergency department in which to place blood cultures, which is emptied once or twice a day, again reinforcing that these are not urgent specimens. The two junior doctors developed educational material, which included this poster, making a link between what might be in the blood culture bottle to the speed of processing and the effect on the patient. Unlike the other poster, this one was not displayed in public areas, but again it made the link between rapid processing of samples and patient outcomes. Following the education campaign, the audits were repeated. The 4-hour target had been met, with 96% of samples now being loaded within 90 minutes of collection. A further audit took place after the two junior doctors left the trust to see whether practice was embedded within the organisation, which confirmed it was. It is common practice for blood science specimens to be collected at the same time as a blood culture. These are usually turned around within an hour of collection. Once staff understand that both the blood cultures and the blood science specimens should be dispatched without delay, it is not surprising that 96% of specimens are loaded within 90 minutes of collection. Where specimens take more than 90 minutes, a reason can usually be found. The patient was difficult to bleed. There was a history of fever, so a form was written and left for a blood culture to be taken at the next fever spike. Or there was a possibility of endocarditis, so several forms had been written up for blood cultures to be taken over a period of time. We will now move on to looking at the impact of optimizing the pathway. The first achievement was the ability to send out real-time 36-hour negative neonatal blood cultures. 100% of negative blood cultures are reported within 36 hours of collection. We know this has an impact because occasionally the interface between the blood culture analyzer and the clinical reporting system goes down, leading to phone calls asking where the 36-hour report is. If the baby is well, antibiotics can be stopped. No antibiotic levels are required. Baby can be returned to mother, and staff can concentrate on the sick neonates left on the unit. The first hospital we compared our E. coli data with was a teaching hospital, which had already undertaken some work to optimize the blood culture pathway. The teaching hospital is part of a microbiology network and contains a centralized laboratory. For the purpose of the audit, specimens arising from the two peripheral district general hospitals lacking a microbiology laboratory were excluded. The blue bars represent the optimized laboratory, which loads more than 96% of blood cultures within 90 minutes of collection. The orange bars show that it takes in excess of 16 hours to achieve the same in the teaching hospital, with blood cultures from the same site. This is further data comparing the optimized laboratory with a regional audit of 5 other hospitals. The first thing to note is specimens in several hospitals take more than 24 hours from collection to placement on the analyzer. Looking at the data in greater detail, it takes 17 hours for the first hospital load in excess of 95% of blood cultures, compared to the optimized laboratory taking 90 minutes. The data presented is the average time in hours from collection to flagging positive for 27 consecutive positive blood cultures containing E. coli. For the optimized laboratory, this was 12.7 hours. The fastest hospital in the region took 50% longer, whereas the slowest took approximately 2.5 times as long, with an average of over 30 hours. However, this is not the end of the story, as further delays are incurred in obtaining results of identification sensitivities of the organism in comparison to the optimized laboratory, which will be demonstrated in the next 3 slides. Going back to the teaching hospital, which had already taken some steps to optimize the blood culture pathway, a complete data set is available for processing E. coli positive blood cultures right up to completion with identification and sensitivities. Load delays produce a 10-hour differential in time to flagging positive on the analyzer between hospitals. Delays in removal of the blood culture increase this differential to 21 hours. The silver bar in the middle of the slide shows a timeline from 2000 hours in the evening of day 1 through to 12 o'clock midday of day 3. In this instance, a positive blood culture signals positive at 2100 hours on day 1, which is outside of normal laboratory working hours. In the traditional hospital, any positives occurring outside working hours remain on the analyzer until the following morning, day 2. This often results in a bottleneck within the laboratory, as there are multiple positive blood cultures to be worked on simultaneously. Laboratories with a mass spectrometer will expect to get the identity of the organism early afternoon, but antibiotic sensitivities will not be available to the following morning on day 3. In the optimized laboratory, processing begins soon after the sample flags positive on day 1, with sensitivity results often available the next morning of day 2. Rapid sensitivity results are usually available within 4 hours of collection. The time delay between laboratories is increased from 21 to 31 hours by the time sensitivity results are available, which are key in managing the patient with gram-negative sepsis. The overall impact of optimizing the pathway is summarized in the next slide. Within 90 minutes of collection, 96% of blood cultures are loaded onto the blood culture analyzer. From 6 hours onwards, hemolytic streptococci signal positive, with group A streptococci appearing between 8 and 11 hours. Rapid antigen testing allows confirmation of the identity of the organism in 15 minutes, allowing therapy to be optimized in less than half a day after the patient presenting. Treatment of severe group A infections includes using clindamycin and the option of immunoglobulin. As 1/3 of group A bacteremias have no obvious clinical source, the microbiological diagnosis is key in ensuring optimum treatment. Strep pneumoniae appears from 8 hours onwards, and again rapid antigen testing gives an almost immediate identification, allowing rationalization of antimicrobial therapy. By 12 hours, over 60% of blood cultures containing E. coli will have flagged positive. Communication of initial blood culture results with a clinician who knows the patient is a true consultation, with a review of the patient, their previous microbiology, and immediate results. By 15 hours, more than 1/3 of positive blood cultures will have been communicated, increasing to more than 60% by 20 hours, and by the end of the day, 86% of all positive blood cultures will have been communicated. At 24 hours, almost half the blood cultures containing E. coli will have been completed, that is from collection to identification and full sensitivities, compared to only 2% in the teaching hospital. On daily morning ward rounds, the optimized processing frequently permits adjustment of antimicrobial chemotherapy in less than 24 hours from admission. The blood culture report in the image was collected at 12:57 the previous day, with the ID and sensitivities being available at 9 o'clock the next morning. Due to the way the laboratory information system has been set up in the optimized laboratory, data can only be gathered in 12-hour intervals, so no changes recorded at 30 hours. But by 36 hours, 88% of E. coli blood cultures are completed, compared to 9% in the teaching hospital. It is not until 48 hours that the teaching hospital is caught up with what was achieved at 24 hours. At 66 hours, the teaching hospital reaches what was achieved at 36 hours in the optimized laboratory. This slide shows in detail the time from collection to flagging positive for various hemolytic streptococci and strep pneumoniae. Combined with rapid latex testing, the clear majority of patients can be managed appropriately within 12 hours or less from collection of the blood culture. Of note, 2 laboratories in the regional audit would not have loaded half their blood cultures by this time. With real-time loading of blood cultures, Staphylococcus aureus may be differentiated from coagulase negative staphylococci by the time to positivity. Blood cultures flagging positive within 12 hours of collection, provided they have not been taken from a line, are invariably Staphylococcus aureus, as they grow faster than coagulase negative staphylococci. Cultures flagging positive longer than this cutoff may be either coagulase negative staphylococci or Staphylococcus aureus. 2 clinical cases are presented to show the impact of optimizing the pathway. The first case, an elderly gentleman, was admitted late on Friday evening and had a blood culture collected just after midnight. This flagged positive 8 hours and 36 minutes following collection. Streptococci was seen on gram stain. A rapid group performed, which was positive for Lancefield Group G antigen. The clinical team were contacted just before 10 a.m. that morning. The patient was on oral clarithromycin and changed to parenteral teicoplanin and clindamycin, the patient having a severe allergy to penicillin. The patient had a very stormy course over the next 48 hours, but eventually was well enough to go home at day 6 with a diagnosis of cellulitis. It is likely this patient may not have survived if the blood culture results had been delayed. The second case is a lady in her early 60s admitted with a diagnosis of diarrhea and vomiting. Blood cultures were collected at 10:30 a.m. in the morning, flagging positive at 6:45 the same evening. Gram-positive cocci staph-like was seen in both bottles, and due to the time to detection being less than 12 hours, the clinician was informed that this was highly likely to be Staphylococcus aureus. The patient was changed to high-dose flucloxacillin and the possible sources of infection discussed. The next morning, Staphylococcus aureus was confirmed, and just as the clinician was about to perform a bedside echocardiogram, a valve cusp ruptured. The patient was transferred to Sheffield Teaching Hospital for a successful urgent valve replacement for Staph aureus endocarditis. This slide summarises the benefits of optimizing the pathway. However, there are 2 I'd like to point out. Firstly, due to prompt removal of positive blood cultures, the phenomenon of Streptococcus pneumoniae autolyzing no longer occurs. Secondly, new rapid diagnostic technologies are coming onto the market, and it is essential the blood culture pathway be optimized to maximize their full benefits. There is a belief in some quarters that every patient is on broad-spectrum antibiotic therapy, so delayed blood culture results are of little consequence. We analysed 106 significant positive blood cultures and found that a third of patients were not on one effective antibiotic. A recent multi-centre study of gram-negative sepsis within the UK had similar findings, with 34% of patients not on an effective antibiotic. We analysed the data as to what would have corrected the initial failure of empiric therapy in the third of patients. The gram stain result, identity of the organism, or antibiotic sensitivities. To give an example of the latter, if coamoxiclav and gent had been administered in line with policy and the organism was resistant to both of these, this would be classed as resistance. However, if only coamoxiclav had been administered and the organism was gentamicin sensitive, this would not have been classed as resistance, even though it was resistant to coamoxiclav. The results showed that the vast majority of failures of empirical therapy would have been corrected by the gram stain. 6 patients were not on antibiotics. Whilst for some of the 6 this was probably a transient bacteremia, others had become quite unwell by the time the positive blood culture prompted further clinical review. A not uncommon reason is misdiagnosing the source of infection as being the chest when it's either the urine or the abdomen, resulting in inadequate gram-negative cover. Patients vary in their presentation. Some are easy to diagnose, but others display few signs of infection or are unable to give a history, making diagnosis difficult. Clinicians seeing patients also vary considerably in experience, are frequently under pressure, so it is not surprising to find patients either do not receive antibiotics or are on the wrong treatment. The laboratory therefore has an important role to act as a backstop in detecting such cases as quickly as possible so that the correct treatment may be initiated. These failures in an empirical antibiotic treatment are unlikely to be eradicated. Although antibiotic resistance came second, it currently only accounts for a small percentage of failures. However, the likelihood is that this will become increasingly important as gram-negative resistance disseminates globally. Organism identity came last, but is particularly important for staphylococci, where until the identity of the organism is determined as a Staph aureus, it is not possible to narrow down optimum specific anti-staphylococcal therapy. Rapid sensitivities are performed in the optimized laboratory to gentamicin, ciprofloxacin, and ESBL detection. In brief, 3 drops from a positive blood culture containing gram-negative rods are spread evenly over an agar plate to which a gentamicin and ciprofloxacin gradient strips are placed and ESBL detection discs. The plate shown has a gentamicin gradient strip and ESBL detection discs. This is the same plate after 4 hours and 5 minutes incubation. The sensitivity results show this to be an ESBL producing organism, which is also resistant to gentamicin with an MIC of 128. The orange bars represent the time to detection of blood cultures containing E. coli. It often takes 24 hours or more to judge whether a patient has clinically responded to an antibiotic, as shown by the red arrow. The yellow lines represent 4 hours of incubation, showing it is possible to get sensitivity results for more than 70% of E. coli positive blood cultures within 19 hours from collection. This puts the laboratory in a position to detect resistance ahead of the clinical response in recognition. Rapid sensitivity testing also prevents undue escalation of antibiotics in those patients where there is a degree of concern, as knowing the sensitivity results will be available in a few hours, as opposed to the next day, it is usually possible to wait and see what the sensitivity is. To give an example of the value of rapid sensitivity testing, an 87-year-old female is admitted with sepsis thought to be of biliary or urinary origin. Initially started on coamoxiclav, this was rapidly escalated to tazocin as the patient was systemically unwell. A blood culture was collected just after 1330 hours and loaded on the analyzer at 1449. After just over 12 hours incubation, it signaled positive at 0304 in the morning and was subcultured at 0320. At 9 o'clock the next morning, the routine sensitivities had not had time to grow, but rapid sensitivity plates showed resistance to gentamicin. At 0945, the patient's antimicrobial therapy was changed from tazocin to meropenem, as analysis of local sensitivity data shows that many gentamicin-resistant organisms are also resistant to tazocin. At 3 o'clock in the afternoon, the organism was confirmed as an E. coli resistant to both gentamicin and tazocin. It is very likely that in a non-optimized laboratory, it would have been a further 24 hours before the patient's treatment was altered to an effective agent. The next slides attempt to explain why serious delays are allowed to occur in the blood culture pathway, despite sepsis being a condition where we know time is of the essence. What do these 3 images have in common? This is the sepsis 6, which laudably includes collection of a blood culture as a key action. This is the National Confidential Inquiry into Patient Outcomes and Deaths, which looked to see whether a blood culture was collected. This is a blood culture analyzer, and it is a belief that the mere presence of such a high-tech machine is that all is required from a laboratory. The answer is that they are all linked by endpoints which do not link timeliness of specimen result to patient care. With urgent blood science tests, clinicians have a peg to hang their hat on, as they know the results should be turned around within an hour of collection. Blood culture is different. Due to the innate biological variability, no one knows at what time to expect a blood culture to flag positive. This provides a shroud behind which suboptimal practice can flourish. Audit is key to understanding how the blood culture pathway is working. However, there is a further important impact stemming directly from this. Clinicians or microbiologists involved in the management of a patient not doing well will be unaware of any preventable delays in processing and thus unable to make the link between delays and to the patient deteriorating or potentially dying. However, one person was able to make this link. In response to a number of high-profile deaths in Ireland, the coroner looked at the timeline of the processing of blood cultures and found them to be unacceptable. Going back to the title of the talk given in Dublin 3 years ago, the Irish National Accreditation Board looked for blood culture standards and chose the PHA SMI B37. This has now been implemented, and any laboratory not meeting the standards is now not accredited for blood culture processing. So one might be able to say that the smart money is on the microbiologists in Ireland. I'd like to thank the numerous numbers of people, especially the blood science staff, who made this all possible.